unmasked your video. Unfortunately, Dr. Yen had to go because it's now past midnight at his local time, and he has a full day of clinic tomorrow. I think everybody's here, so we'll go ahead and unshare the panel. And you're welcome to put the panel into a gallery view if you want to see all the smiley faces. There were a lot of questions that we didn't get to, and maybe I'll just start off with one. There were several audience questions about different either pediatric or adult patients and monitoring. So I was wondering if Dr. Hammond and Dr. Barris can comment on the adult and pediatric, or in general, what's your expert opinion?
On monitoring?
Right, so using ophthalmic imaging. So once you diagnose optic disc drusen, let's say with EDI OCT or on-FOS imaging or all of the above, which is what we tend to do at Stanford, what's next? How frequently might you monitor the patient, and what do you tell your patients?
Okay, so I can start off. In the ideal situation, I would ask all of them to come back very frequently because I'm very interested in this condition. But unfortunately, my boss, he disagrees with me that the optic disc drusen is the most interesting disease in ophthalmology. So we're not really allowed to, at least in my facility, to monitor these patients at a regular interval. So we usually only see the patients who have complications, and if we're able to provide some kind of treatment to them. Otherwise, it's just information purpose. And I use quite a lot of time to inform them about what we know about Drusen, and what the risks are for them to progress over time. Usually it's low risk, but we do of course also inform them that there is a risk of capturing an AION, and as with all optic neuropathies, it's important to not smoke and to go through your regular checkups at your GP to check the cardiovascular status, as it also may be important if you have an underlying optic neuropathy as Drusen. So apart from that, it's more or less information. And what we also do is that the patients, they are enrolled in our research purposes, and we ask them whether it would be okay for them to be contacted with other research projects, but also if eventually we get to some kind of treatment, we can call them in and treat them.
I would say for the pediatrics is a little bit different. I see them in kind of two camps. The first is the camp of newly diagnosed optic disc swelling, and we think it's optic disc drusen. We see some optic disc drusen, but in children, there's these fluctuations that we see in terms of swelling, despite it only being optic disc drusen, which sometimes throw us for a loop and also get us a little bit more anxious that we might be missing something. So for pediatrics, I would say that if I see a swollen optic nerve and I see on OCT EDI that it's optic disc drusen and there's no other symptoms, then I probably have them come back in about 4 to 6 months just to make sure there's been no changes. If I see a kid who has changes on the optic within the retinal nerve fiber layer thickness, then I would probably shorten that interval just to make sure I'm not missing anything. And any new symptoms, I would then proceed to work up for papilledema. The second group of kids, I think, are the ones who we've seen that it's optic disc drusen. I follow them maybe at the 6-month mark and there's been no change. Typically, I will have them come back for a visual field before driving, because that's the most important thing, that we know that as these drusen move forward, typically the time frame becoming superficial to a visible drusen is in their teenage years. So I don't want to miss that time frame of following them. And then in addition, we know that as the drusen become more visible, they're at more risk of having visual field loss. So typically, say I see a 12-year-old who has optic disc drusen, I'll see them either yearly or tell them to come back in 2 to 3 years for a visual field before their driver's test.
Terrific. I definitely wonder about key biomarkers for segregating the population that's going to lose vision versus the population that it isn't. And definitely wonder about the volume, studies that Dr. Hammond is doing, the vascular study that we've done. We actually found that macular vasodilation, so increase in the vessel diameter, is an indicator of some kind of auto-regulatory compensation potentially to the compression. I guess we'll get to it at the fourth session when we talk about designing a natural history study.
Can I add one comment to this, Joyce?
Yes.
I think we've found some interesting things that, as I mentioned in my talk, that if you have a large drusen, the larger drusen you have, the more severe visual field defect in a way. So that goes for the slow progressing visual field defects in drusen. But for the ones who have the AION, we find that the location of the drusen might actually be more important. So you can have one little tiny drusen at the wrong place, and you get an AION. So in that case, it's not really the size that matters; it's the location, and that makes it even more interesting. So we're starting now a prospective study with AION patients, as you know, Joyce, the narrow study, and we're specifically going to look at the location of the ones that get AION and have a drusen in terms of OCTA and all the different kinds of modalities.
Is your hypothesis that the more temporally located the drusen are, the more likely they are to have central vision loss?
I wouldn't say that directly, but it could point in that direction. But I'm not sure yet if I can say that.
Yeah, since Yen isn't here, I'll just briefly mention our recent publication doing quadrant analysis of optic disc drusen, matching the visual field to the location based on the Garway-Heath map. It showed simply that the nasal and superior quadrants were the most affected. However, there were other indicators such as vessel area density or vessel complexity index that seems to be correlated even in locations where there's no thinning in the OCT. So we kind of wonder about the OCTA, as Dr. Hammond mentioned, as an early indicator of changes that may then lead to vision loss.
I had a question.
Oh, go ahead.
I thought it was interesting in the Israel study with children where the FOMs are found in the pseudopapilledema in the children without optic disc drusen, which we know that they're found in all different types of optic disc edema. But in those, they found that about 94% of them had hyperreflective foci, not necessarily the bands. I wouldn't say they were linear from what I could see in the study, but just small foci. I think it was appropriately described as that. What do you think of that in terms of this continuum of so many of our patients who have pseudopapilledema that don't progress into optic disc drusen? And do we think that this is a continuum? And Dr. Moss, do you feel like this is something that the children who end up with the drusen that are formed, is this a stress manipulation of the axons?
Yeah, I mean, I think that's a very interesting question. And there's actually a question in the Q&A asking, are drusen a biomarker of a poorly defined primary axonopathy, or are they a cause of the axonopathy, or is it both? And I think that's a really interesting question. I mean, the genetic predispositions would argue that it's not just purely a mechanical axonopathy, unless somehow the genetics are leading to something structural that's provoking that. And I think it's a really interesting question of cause and effect in chicken and egg, and what sets everything off. And I think looking at some of these, large population studies, I think the Copenhagen study is a really nice one of seeing how these things evolve over time will start to teach us about what are the paths or the stories that these patients follow as they progress, and that will help to inform our hypotheses about what's going on.
In the Copenhagen study, did you guys look at the hyperreflective foci within the FOMs in those patients over the 5 years?
Well, let me just phrase it otherwise, because you started with the Israeli study and you showed this with the hyperreflexive foci, and that was inside the optic nerve head, right? It was not the peripapillary as I saw, at least the image that you showed. And I think that what you see as these hyperreflexive foci using ultrasound, I think it's probably hyperreflexive lines or like fractions of hyperreflexive lines instead of FOMs. I'm not really convinced by the ones saying that they can visualize the FOMs using ultrasound, because I believe you need a calcification in order to see that. I don't know if it was a strange way of answering your question, but I think it's more or less what you're alluding to, right?
Well, I wonder about the hyperreflective lines are due to calcified mitochondria. As the audience mentioned, this could be a reflection of an underlying axonopathy. But as we know, mitochondrial issues, so just to remind everybody, optic disc drusen, we think it starts from calcified mitochondria. Mitochondrial issues due to heteroplasmy and the intense concentration of mitochondria at the optic nerve head, there may be a threshold effect. So I would think that metabolically there is some room for preservation until it kind of hits a point of no return. But this is a unique condition, different from other mitochondrial optic neuropathies like Leber's hereditary optic neuropathy, because of the superimposed biomechanical aspect, which is related to the hyperreflective lines in the Drusen. All I could tell you is I have patients who literally have 2 hyperreflective lines, and that was diagnosed after they developed ischemic optic neuropathy, either at high altitude or from sleep apnea, other risk factors. So these are big questions that I hope Dr. Hammond's trial will be able to answer.
Well, I think one of the big challenges, as you said, they were diagnosed with hyperreflective lines, and I think a question came up earlier, is do other optic neuropathies increase risk for Drusen? And certainly there's been some chatter that perhaps having papilledema, or in this case, NAION. So, we know that patients who have Drusen are at higher risk of having NAION, but does the inverse apply as well? Or maybe are all of these, quote, discs at risk actually Drusen that we can't see, that they're really small? And it's just it seems like the more I learn, the more questions come up.
Well, it's great that we're talking to each other and having this fantastic meeting. I want to make sure Dr. Doe's questions get answered. So there are actually a couple of them. One is related to repetitive traumatic shearing as a contributor for developing neovascular membrane. And another is on anti-VEGF treatment in ODD-related CMV. Can you comment on both of those?
Sure, I'd be happy to. The question about traumatic shearing is quite interesting, because we know in certain trauma cases, people can also develop choroidal neovascularization because of, let's say, breaks in Bruch's membrane. So that could be a contributing factor in the peripapillary region. And it could lead to a development of CNV as well as a potential etiology. What was the other question about anti-VEGF, Joyce?
Oh, just if there's any particular treatment regimen you would recommend for ODD-related CMV. Is it like any other CMV, or it requires some special care?
I think discussion with your retina specialist and formulating a treatment regimen is important. Usually in most of these cases, we treat aggressively in the beginning. That means it might be monthly therapy with our current anti-VEGF agents. And once the lesion has become quiescent, then many retina specialists would like to employ perhaps a treat and extend regimen, where the number of treatments will decrease over time. Certainly with small lesions, many of these patients may only require a few treatments during the first year. And then if the lesion becomes inactive, then close observation can be done in the future. So I think that the regimen needs to be individualized for each particular patient.
Thank you so much. Well, in the interest of time, we're going to have to pick up these discussion at the next session. So we're going to take a very short